Good afternoon and welcome to the 2018 season of the Brown Bag Webinar Series. This is a webinar featuring Virginia hospital strategies in promoting safety culture and high reliability. My name is Joan Williamson. I'm the director of the Virginia PSO, and on behalf of the VHHA Center for Healthcare Excellence and the Virginia PSO, I'd like to welcome you to this continuing series of Brown Bag webinars. Today's presentation is Patient-Centered Care, Let's Not Forget About the Ending, presented by Inova Mount Vernon Hospital. Today's presenters are Jennifer Shepard, clinical social worker with palliative care, and Florence Freire, a frontline nurse who has something very special to share with you, and Corinne Wawa, the clinical director for oncology, the dialysis, and the infusion clinic. Before we get going with the presentation, I want to just go over a couple housekeeping items with you. Well, I'm having a hard time getting the slide to advance. So I'll just go ahead and talk about housekeeping issues. I'm trying to go backwards. This webinar is being recorded, and slides will be sent out following the presentation. We'd like for you to use the telephone option for audio prompt because we find it to be most reliable. All participants are muted. We'd like for you to enter questions that you may have into the chat box. You'll see where the blue arrow is, and we'd love to be able to answer your questions with our team that's presenting. There'll be a feedback survey at the end of the webinar, and we look forward to your participation in that as well. That being said, we're going to go on to the Mount Vernon team, and so Mount Vernon team, it's all yours.
Well, thank you for the opportunity, and thank you for joining us this afternoon. Well, we're going to be talking about patient-centered care, but not let's forget about the ending. My name is Corinne Wawa. I'm the clinical director for the med oncology, the infusion clinic, as well as dialysis. I'm here with my team member. I'm going to let them introduce themselves.
This is Jennifer Shepard. I'm the LCSW for the palliative team here.
This is Florence Freire. I'm Unit 3B.
And the reason we really wanted to present this is one of the objectives was to introduce our hospital organization to provide the importance of end of life, to increase awareness of palliative care and hospice care, to identify barriers and challenges we encounter, and to highlight methods of sustainability. Next slide, please. So let's talk about our organization. We all team members from Inova Mount Vernon Hospital, and Mount Vernon Hospital was founded in 1976. It's a hospital with 237 beds, and we offer patient convenience and state-of-the-art care in a unique healing environment. Next. So this is what Mount Vernon has achieved so far. We achieved the American Heart Association, American Stroke Association awarded for Gold Plus elitization for its premier stroke case. We received the Press Ganey Guardian of Excellence 95 percentile for 2015, 16, and 17 related to our emergency department, who are very phenomenal with their work. They do in quality and patient satisfaction. We earned A since 2014 on the Leapfrog Hospital Safety Grade. We were recognized nationally by the orthopedic surgery as being the 21st in the national and #1 in the state of Virginia. And recently we were recognized by Niche as a senior-friendly hospital. Next, please.
This is Jennifer, and I'll just give you a little background of palliative care and what it looks like at this hospital. And I just thought this quote was really appropriate for today. Death is an inevitable aspect of the human condition. Dying badly is not. Next, please. So, curative care focuses on curing an illness and prolonging life as long as possible. Palliative care focuses comfort and quality of life that can also be provided with curative and aggressive treatments. Hospice care is where we focus fully on comfort and is ideally for the last 6 months of someone's life. Next, please. So palliative care, our treatment emphasizes comfort and improves quality of life. We want to try to relieve patient symptoms, not just physically, but the emotional symptoms and the stress that they have, as well as spiritual distress. Next, please. So just the World Health Organization, palliative care provides relief from pain and other symptoms, affirms life, and regards dying as a normal process. We're not here to hasten or postpone death. We just want to be supportive to the patient and the family for the difficulty that having a serious illness brings on. Next, please. We support not just the patient, but also the family to help them cope, and in certain situations can provide bereavement care to them as well. Again, our main goal is to enhance the quality of life, and it is appropriate for patients to get palliative care even at the time of diagnosis so that we can keep following them throughout the illness as things progress and continue the conversations to determine what their wishes are. Here at this hospital, I am the full-time only social worker on the team. We work really closely with the chaplaincy program, and we have 2 physicians and a nurse practitioner that rotate each week to provide the services for the physical symptom management. Next. So we just recently worked really hard to be able to start providing GIP hospice beds in this facility. And Florence, the frontline staff, is going to just share her experience with that.
Hospice care provides support and care for those in the last phases of life-limiting illnesses. It also recognizes dying as part of the normal process of living, affirms life and neither hastens or postpones death, and also focuses on the quality of life for individuals and their family caregivers. At Inova Hospital, we had a 2-hour session or training for nurses to be able to care for an inpatient hospice. For me as a nurse, it gave me the tools to be able to work better or to be able to support the family as they are going through this difficult phase, and also be an advocate for my patients as they just have making them as comfortable as they can be through this phase of life. Next.
So advanced care planning is a big part of what palliative care does. A lot of people kind of use the term goals of care to describe that as well. But I'm sure we've all had experiences where this isn't the easiest conversation, not only for physicians, but families as well. And some of the reasons is just denial and the sense of immorality of, death isn't going to happen to me, or they just don't have to think about it and put it off. And as quoted here, some people might say that if you have these conversations, they'll lose hope in the illness, or she'll just be depressed and wither away and die when we have these conversations. But we try to work through these misconceptions as much as the patient will allow us to hopefully work towards having a productive conversation. Next, please. So this is palliative care is patient-centered care, and we try to involve the family in these conversations as well. The biggest starting point for us is just trying to gauge what the patient understands as to what's going on. A lot of times, doctors give patients information, and patients sometimes hear it as something completely different. So we try to work through all of those confusing medical terms to help them have a more easy to understand explanation. What are their expectations? And really, how do they want whatever time they have left to be spent? And and how can we help them attain these expectations. Next, please. So we base the conversations on the current condition and what's happening now while they're admitted to the hospital, but we also talk about the future and what to expect with their illness, and this allows them to be able to identify what their goals are and realistic expectations. Next. So a desired outcome of advanced care planning is a sense of control. And I really try to hone in on this when talking to my patients and recognizing this to be one of their biggest strengths if they are able to continue to speak for themselves and make these decisions. I don't think people realize how difficult it is for families to have to make those decisions. And if patients are still able to speak for themselves, it really is beneficial to the family to know exactly what their wishes are. We also want to assure comfort and dignity and encourage trust in healthcare providers. It can be really confusing, patients and families, to hear from different doctors, so we really try to kind of look at this from a broader perspective as well. Ideally, for patients to recognize and accept that death is inevitable and that they have the ability to tell us kind of what they would like their death to look like. And it provides them time to be able to prepare for closure and being able to say goodbye. Next. So this is just a good explanation of the difference between a post form and an advanced directive. So since this is for Virginia, I am specifically talking about the Virginia post. Each state has different forms, but it's generally similar. So the post form is for the seriously ill, and the healthcare professionals help the patient and or the family complete this. The family or the patient spokesperson is able to fill this out on the patient's behalf. It does require a physician order, but the good thing about the post is it goes from the hospital to wherever their next place may be, whether that's a skilled nursing facility, nursing home, or to their own home. Advanced directives is the general living will. Only the patient themselves can complete this. This is where they would put who they want to speak for themselves if they couldn't, and it's the generalized, I don't want to be kept alive on machines if my death is imminent kind of a conversation, where the post gets a lot more specific. What's not included on here that we also can help patients complete is the durable do not resuscitate form, which the same answers would be listed as the post on this slide. Next. The post is typically for patients. They ask the question of, would you be surprised if this patient dies within the next year? If the answer is no, then a post is appropriate for the patient to fill out. It is a specific training for people to go through to be able to fill out this form, but I think they do it pretty widespread across Virginia. And a lot of healthcare professionals do like us to have those conversations because we're kind of used to it, and it's not an easy conversation for a lot of people to have. But we try to really stress that this does not mean that people are giving up. Next. So this is just what the form looks like if you've never seen it. This is why we like it, is because the top part specifies about resuscitation wishes. Part B is where you get into more medical interventions like ventilation, vasopressors, and you can get more specific wishes from patients. The third part specifically asks about nutrition and hydration. These are really good for us to ask patients. Next. What we've been trying to start using is what is called Muse score. It stands for Modified Early Warning System, and it's calculated by patient's respiration, pulse, blood pressure, consciousness, and temperature. And if you see on the right-hand side of the screen, the colored boxes, green is best, red means they're not doing very good, and yellow and orange are in the middle. So if we see someone orange and red, we definitely take a deeper dive and see if they're appropriate for a palliative care consult, and then we'll ask the physician if they can order it. Next.
Well, as you heard my team member talking about the work that we're doing with palliative care and hospice. So Mount Vernon is now inpatient hospice, as Jennifer has mentioned earlier, and we partner with Capitol Caring. And our palliative care team is very, very involved. And one thing we do here at Inova Mount Vernon, we have a promise that we say we seek every opportunity to meet the unique need of each person we are privileged to serve every time, every touch. So we're here to serve even the people who are dying. So we also, while taking care of those patients, you are taking care of not only the patient, also family member. So on units when we have a loved one that's dying, we provide comfort care from family members. And as Flo mentioned earlier, hospice education has been ongoing for the staff to help them take care of patients who are dying. You know how very we see pushback when it comes to medication. Sometimes we are comfortable about medicating those patients, but through the education, as Flo has mentioned earlier, it had helped us saying that, oh, now I'm comfortable about giving those patients those medications. And the other thing we are very proud about is since May of this year, we had a patient, we've been going without a patient dying on us knowing the wishes. So this is what we want. As the stepper in our hospital, as a stepper in our organization, like we say, we seek every opportunity to meet the unique need. So what we're looking for is, are we meeting your wishes? Next, please. Again, it's all about how you live. Learn about your options, choice, and decision. Implement your advanced directive plan. It's very important because we need to know what you want. Voice your decision about hospice and palliative care. Engage others to learn more about hospice and palliative care. This is the end of our presentation. Do you have any questions for us? Next. Thank you so much for taking the time to listen to us. We are happy to have answer some questions that you have for us.
I don't have any questions coming in yet. Thank you so much, Corinne and the Mount Vernon team, for this wonderful presentation. I'll be looking at our chat. If anyone has any questions, we'd like for you to chat them in the chat box, and we will be able to address them with our panelists. So I'll have one question for you while we're waiting to see if any other questions are coming in. And one question is that I have is, what are some of the successes that you've seen with the implementation of your recent inpatient hospice program?
Okay. Well, I will be the best person to speak with that because I am at the bedside with my patients and their families. I am a novice nurse, so I went through the training and I went through the program. So I was educated and given the tools on what to do. For example, if I get a patient coming to me from ED and I ask them through the admission process, I can trigger their palliative questions and trigger Jennifer here, and also notify my doctor about this patient's wishes. And also, I'm also comfortable having the conversation. I know what to say. I know how to just open the conversation up with their family present or without their family not present. And also, if I get a patient coming to hospice to me, I know the medications, I am comfortable giving the medication because it makes them comfortable. When the patient is comfortable, the family is a little bit at ease of what is going on. They don't hear their family member being in restless or in distress. They just see them as comfortable as they want them to be when they are at the end of life. And so for me, it has been very, very helpful. I'm much more equipped to be a better patient-centered care on that aspect.
And to those about what Florence has said, one of the things on the with what we did with, especially on the 3B medical oncology, this is a unit when we see a lot of people that are dying. And one of the feedback we receive from our family members is it usually happens when they step away from the room, when they have to go either in the cafeteria to get some coffee or something to drink. By the time they're in the cafeteria, they heard that, oh my God, the loved one had passed away. So with that feedback, if you heard earlier talk about comfort card. So the comfort card, in collaboration with our food service and nutrition, they bring coffee, hot tea, cookies, food for the loved one, so they don't have to leave the bedside or to be at the side of the loved one.
And also, sometimes as nurses, we try to make sure they don't get so many distractions by people going into the room at this point. So we kind of close the door. We put a sign there letting them know if they need to go in, they should come to us first before they go in. We also honor the wishes of the family if they don't want more people to know that their family, they just want to keep it private. So whoever is coming to visit me says, oh, she's not here, I'm sorry, you can't see the person. We just go like, call this person or that. So we are able to maintain that private moment they want to, or that little moment they have with their families, and they can get the most out of it also too.
Thank you so much. We don't have any questions coming in. Would any of your team like to have any closing remarks?
Well, I think it's Stacy, and I think that I'd like Jennifer to talk about the advanced directives, and at what age should you actually start thinking about advanced directives?
I think every person should start talking about advanced directives, but as we all have seen, it's hard for people to even hear the word advanced directive and want to have that conversation. But the population here in this area, the majority of our patients in this hospital are 65 and over and do not have any form of a living will or advanced directive. And it's hard once they come to the hospital. Sometimes it's too late to have that conversation, and it really ideally should be started outside of the hospital setting, whether it's the primary care doctor or just the community that the patients are in, to inform this community about advanced directives and how important they are. Obviously, we're happy to help them if they're open to having that conversation. We can help them fill that out easily here, but we would really like to see a lot more advanced directives being completed. So that's a big goal of our hospital here, to even help the community out in educating them.
All right, well, thank you so much, and we appreciate so much your presentation. This gave a lot of great information on post-advanced directives and the hospice, and as well as the benefits of having an inpatient hospice program. Thank you, Mount Vernon team, and we will give you back 6 minutes of your time. Thank you all so much.
Thank you.